Where is superior patella for you?
here.
Okay, there, yep.
Initially it's here, then
Mm,
after one session, this one no more,
mm,
but it's like around the patella. And
mm-hmm.
she felt it's center inside, like
Mm-hmm.
in the middle like that.
Yeah, okay. And she feels problem in a deep squat or
In
coming out from a deep squat.
first session is staying in deep squat. The
Yeah,
second session is coming up from deep squat.
but staying in deep squat was okay after that.
Yeah.
But that's body weight, right?
Mm.
Okay, and then deep squat is what deep squat? Asian ass to grass or like the deep squat as wobble deep squat?
The Asian squat.
Asian squats. Okay, can. Um, so you are my criticism of this one is you are very layer one and concerned over the layer one. Why?
Because I tried to rule out other layers initially,
Mm.
and I found layer 2 is okay. So I jumped back to layer 1 and 3. My treatment is done on layer 3, motor
Mm.
control everything, it
Mm.
improves, but then it's not sustainable. So I try to find out what's really going on first, so I can maybe I know what I'm doing better.
Mm. Mm. Okay, so when you write that, my impression is okay. There is the ultrasound, right? What do you think of the ultrasound?
Assist of help me to know better, is it why like this part is more squishy, is there any inflammation?
Yeah. So in the ultrasound, you only wrote some extra calcification. Betul? Okay. Is the then with the extra calcification, is those area consistent with the area of she causing pain?
Yes.
Yeah. So the ultrasound goes over the spot of the extra calcification site, and then what's the name? Shafika would then press the area, and that is consistent with the area of pain. Agree?
Yes.
Okay, can. Good. Then where is the calcification area that you mentioned?
Is superior to the patella.
Mm-hmm.
The other one is medial. Yes. Medial to patella.
Medial or medial inferior?
Medial.
Medial, huh? Okay, can. Now, why do you think a calcification developed?
Extra stress that the knee cannot take, so it's an adaptation.
Mm-hmm. From the bone or from the anticyst organ?
Sorry for the bone.
From the bone or from the anticyst organ?
Bone. Think it's from the bone.
Don't know. Don't know.
Okay.
So, for example, if you talk about the superior end of the patella, like sonography sees a hard calcification with shadows underneath it, right? And that extra calcification could be a tugging of the tendon onto the bone, then lead to this. Then the management is slightly different. That there's an extra load that the body cannot adapt, blah blah blah, and so forth. The bone part on the medial end could be the MPFL, or it could be the osteophytes formation from patella itself. That's what you're alluding to, right? Does it make sense? Okay. Then the second thing is you mentioned something squishy. What describe that squishy? What is squishy?
It feels like there's effusion inside part of squishy. So when I do a patella pad,
Mm.
the left is okay.
Yeah.
Like on top of this one is okay.
Correct.
But the right side it feels like more bouncy kind.
More bouncy. Good. Okay. Now, you already had a sonography. Betul. So, what did the synovial capsule look like?
She didn't say anything lah.
Itu bukan my problem.
Okay.
Because then, you can then show it to a patient that to say, you see, the cartilage thickness, the space in this area is nice and beautiful. through the mountain groove view, right? You can see that suprapatellar view. So you can know that the intra-articular cartilage surface is nice. Okay? Then you run it through the side here, your so-called squishy. It can have two things. One is a patella that is a little bit more medially glide, but with a lateral tilt due to lateral structures being tight. So when you press on it, if it's got more space to give, can you get it? Like, so a patella that is a little bit more medially and a little bit more lateral tilt. So then when you press down, there's an extra squishiness onto it. But since you already had a sonography, and that applies to everyone, is you have to think with Shafika. You say, I found this squishiness. Can you tell me, am I seeing an infusion or a synovial membrane adaptation? So then she will have to measure side on side, and then she will see a hyperplasia of that synovial membrane. Then you got your answer whether am I dealing with the pouch of synovial membrane of the knee, or am I dealing with patella that is a little bit more tracking differently, or am I dealing with a cartilageous loss? That's it, makes sense. So that needs to be interpreted a little bit more, right? Because you are not a baby already in this clinic. So the level of understanding the level of understanding behind this, I need to let you know and think a bit more. Because then, that's the reason why I really wanted focus within our session. Because sometimes I cannot make that decision. I make a best guess decision and follow through. But my best guess sometimes is wrong, so therefore, if I got ultrasound proof, then it's easier as such. And then you said there was no investigations and all, and most of the time, investigation probably will not report on it as such. Okay? In patellar pathology, in patellofemoral pathology, patellofemoral joint syndrome, I'm going to go around the room, not you. What are the pathology that you can think about that is relevant in this particular patient scenario? Okay, we're looking at layered concept. We're looking at, what can you remember? What can you recall? Give me. Huh?
It could be bursitis.
Okay, so bursitis. So so the bursitis, where does the bursa present?
Since you said it's like the lateral part, it could be the past answering. So that's like
Bursa, it's a lot more lower down, and that bursa doesn't usually thicken too much. You have your bursa / fat pad structures in the infrapatellar area, and that area is also just an area of cushion and tissue. There can be innervation, so the area can be painful. They will have a pouch, and then you go underneath and you squish on it. It's a little bit painful. That's why a nice beautiful archistop onto it is nice, not on the tendon. However, a tendon pathology often comes with a bursa that's irritated because tendon weak, cannot hold well. The stress goes into the retinaculum, goes into the bursa, and goes in, and then as a form of load transference, and they become painful. Alright, so that is your bursa. Right? So moving on, Lavinia, what other kneecap pathology can we think about? We go through layer concept, though technically this patient has to be managed with a functional approach, not motor control approach. Patient is pain provocated through specific movements, betul. So the layered approach only serves as a guidance at this point. Any patient that presents with pain first and in multi-different function, then you go layered approach, very nice. But in this patient, the pain is only provoked in specific movement patterns, then you need to go functional movement patterns approach. Right? So that's where we're going to go through. But we're still at layer concept. Lavinia, what conditions can you think about?
in the layer concept.
Sure, that in the kneecap. Don't give me meniscus lah.
You
Okay, yeah. So describe the pathology that could happen around MPFL.
She goes like a person flexes the knee and
Uh-huh.
has any restricted movement of the tibia not being able to glide.
MPFL 喎 medial patellofemoral ligament
Or the whatever that's called.
Uh-huh.
Overly stretched.
Retinacle overly stretched. No, when does MPFL gets injured? I baru just saw a nice beautiful in rugby that the MPFL was torn.
Pivot.
Huh?
Pivoting.
It's a pivot, but rather than this person, rather than pivoting over the meniscus, the MCL, the lower part of the pes end, the pivot happened a little bit more valgus, like the kneecap just went. Remember that same position we talked about? The vastus and rec fem is pulling him laterally, alright? Pulling him laterally. So there's a tilt force, and that tilt force is enough to go inside. Was diagnosed as plica, but plica doesn't attach from here to here. So femur on patella, I baru just diagnosed one. It's torn. What do you want me to do? You can reconstruct it. So you can have tear, you can have stretch, but the ligaments goes through valgus stress. And it's not called through tibial femoral in this particular scenario. It went through just a little bit, just change your direction, and then because it's lateral tilt enough, it's just going to because it's contracting further through. So that one very simple, just patellar tapping, and the usual tapping that you guys do, which is to pull it laterally, is worse for it. This literally is just compress it down, so some circular donut type thing. Compress the patella down, he feels symptom relief, and there's nothing I can do. Alright, so ultrasound can also see MPFL.
Check is intact.
So you check or she check?
I asked her to check.
You ask her to check. Good. Okay. So this is in the mind that you have to go. Good. Well done. Now, Shani, good morning. Subang run club today, I think. 1, 2. This one no more Subang already.
I still as a president, ma.
As a president. Yeah.
Still a president, huh?
Come on, God. So, what other pathology you can?
Must be in this.
Kneecap. Anything around the kneecap. I don't want to hear ACL. I don't want to hear meniscus. I don't want to hear PCL. I don't want to hear MCL, LCLs. Retinaculum can, but don't. There's plenty more. Mm. Yeah, so wearing off the cartilage, what do they call it? Malaysia. Again, Malaysia means softening of the cartilage control surface, right? So, under Malaysia surface could also happen in the mechanism that I was describing. There's a little bit more of a lateral shifting and a little bit more lateral tilt. So the bottom of that becomes very much tilted. So the bottom horn here goes onto the groove, then it becomes very sensitive. And that's where you have your, I think it's a crack test or something like that. You compress it and you and then you reproduce a deep pain inside. And it,
anyone also pain
no, I think CrossFitter only. Because later on we're gonna talk about functional approach. So, but it's more like it's a groove that should go C-shape, but they focus area of pressure. Sometimes it's a lateral surface onto the femur condyle. Sometimes it's a surface, and you critique that particular test. That test was done in extension. So would you achieve the contact surface of the patellar surface? Would you touch the wound side on the patellar side? Yes or no? So if you talk about the cartilage underneath the patella is wounded, therefore chondromalacia. So when you do that test, pop and glide it and move it, it hurts. This is causing the patella end that's irritated. What if the person bend the knee, then it hurts, rather than in straight, then it hurts. So with now, if the wound is on this end rather than this end of the femur, when you do that test, would it hurt? It wouldn't hurt. So you may have to do a different surface of the same special test. You have to get them to freaking kneel on the ground and circumduct and shear the cartilage surface, and then they get, oh, that really don't like my knee pain. Now, there is no contractile element when you are kneeling. There's only compression over the surface of cartilage on cartilage. Betul. So now you can get a little bit more idea. Physios are fun in a way that we don't really need investigation. I always tell people, investigation is only for me to rule out something that I'm already worried that I need you to go for surgery. All my direction is totally opposing. One says go into extension in the lumbar spine, and one says you need to avoid extension temporarily. Then I'll be like, yeah, if can give me an MRI. Right, so that's what I would recommend for you to think about. If you're thinking cartilage surface there, we need to know why we do that special test to begin with, right? And remember, the curvature of it is different. The contour of the femur is different relative to the patella. Okay? The lateral femoral condyle is a little bit more uphill rather than the medial condyle. So if it's a little bit more laterally shifted, it's already gliding here, and then it's going through this process like that. So like this is lateral, this is my kneecap, femur, medial side I don't have. It is being pulled laterally and further to this. Okay, so there's a surface here and a surface on the patella this end that could be irritated. Faham? Okay, so therefore it still feels in the inside or underneath the kneecap as such. Alright, so we have a layer of chondromalacia. Other descriptions of it is the mountain groove is a bit shallow. So the shallow one will then require a lot more adaptations on your patellar pouch. Your patellar pouch has to be thicker and stronger to hold that in its groove. Short of that, there's too much tension. Those you will see a lot more pressure around here. So if you take an X-ray, you think of a view in that position. The rather than two deep grooves of a mountain, the mountain's a little bit flattened one. And that flatten makes the extensor mechanism from your quadriceps into your patella, into your patellar pouch, into your retinaculum have to have adaptation. And those adaptations can cause pain around the knee. Faham? Okay, so that is your chondromalacia patella. Okay? Uh-oh, it's getting harder. Let's move on. What other pathology can you think about in
Can I say retinaculum tear?
I already said try not to mention retinaculum. It's on the boring end, but okay.
Uh,
So retinaculum is an adaptation, right? We need the adaptation to occur. If the retinaculum means that the vector force, particularly the medial capsule, when you think retinaculum in this scenario, you have to think the deeper surface and also the superior surface, right? The deeper surface is a medial joint capsule of the tibia on femur. So in a classical OA presentation, there is anterior shift of your medial side.
This one.
So this one in extension is a bit more medially shifted. So when it's medially shifted on the anterior end of the medial femur condyle, your retinaculum, your joint capsule here, will have a tension and stress. You will see that when they walk, when they go boom down, okay, they go into valgus, they get this stretch in this particular area. Think about that component. After that, they start to have a counter, either a compression or a counter rotation backwards. That's why they always complain of lateral calf pain. And fixing it is not coming from here, fixing it comes from here. Okay, so we possibly are dealing with a medial joint capsule in a OA presentation or a laxity presentation, or even a high-end athlete that looks a little bit of a, you say patella looks a little bit more medially positioned or something like that, right? In your so mention something along those lines. So you can probably you need to think that, because it's easy to say the retinaculum. Retinaculum, ideally I want to see retinaculum on both sides being stressed. That means it's an extensor mechanism that I just talked about. The chondromalacia with associated flattening of your mountain grooves. Therefore, extensor mechanism had to work harder. Then it could be anticiopathic changes of the quadriceps insertion that could lead to bone calcium deposits on the patella. Okay. Or you have your Pfjs tightening and also bilateral retinaculum. If we talk about purely medial one, you cannot not think about medial joint capsule. That is going the same thing. We talk about layered concept. You have to think deep before you think superficial. If the retinaculum on the medial side is affected and that's your diagnosis, you have to really tell me that is only there. Because there is a potential adaptation deeper down that if you don't address it from that end, you are likely gonna not work. I mean, you can. Just means that people will put you on social media and says, help me a lot, but 2-3 months later you come back complaining and must see Marcus now. Only Rebecca knows who they are talking about.
But with people that will have a relatively tibia to the femur, then
Itu nanti dulu. Today we are talking patella femoral, because I wanted to, but then I end up will be like I was talking to my good friend ChatGPT, and when I start right about what I want to teach and all those things, then I went into tibia femoral, right? Oh, jialat liao, the meniscoid lah, all those things that's coming out, and what to do about how to measure around the hip from bone perspective. That's a different story. Today we purely think and imagine this is a beautiful case study only on the patella. But in patella itself, you can hear 1, 2, 3, 4 already. Satu lagi.
Can I go like super simple and see quad tendon?
you will.
Quad tendon presentation in this scenario, okay, can be described in medical text. So you have what physio knows as inferiorly tilted patella versus superiorly tilted patella. Faham? We got medial lateral, right? Remember, you got inferior and superior. Okay? The exact name of it, they go very fancy Latin words, okay? Like patella alta. Alright? And the other one I forgot already, so don't bother. Okay. But all you have to know is patella can tilt superiorly and inferiorly. So if you have a superiorly tilted patella, what would be the pathology associative to it? Hear me, it's associative, not quad tendon. Oh, sorry, it's quad tendon. What am I talking about? She's looking at me blurred, and I was like, so no. What I'm trying to say here is, if a patella is more superiorly tilted, you cannot just classify it under quad tendon. More so when you assess for quad tendon already, you need to think about this superiorly tilted, whatever that is causing this adaptation here, and most likely is due to fixed flexion deformity. The knee is in a little bit more flex, therefore there's a little bit more patellar quad area, so therefore certain early surface of the patella is in contact on the femur condyle. Now if it's inferiorly tilted, will be what Leon says, the retinaculum, but bilateral retinaculum adaptation. You have a patellar tendon adaptation, right? That will also be associated with the opposite of the knee, hyperextended knee. Oh, the wrong way.
Hyperextender is this lah.
He's pointing on his patella. I thought his patella.
Oh, no.
You talking about knee on tibia on femur, or you're talking about patella? Because you do it. Patella, then your patella should be down. Inferior, and you're more hyperextended. So therefore you get those adaptation there. And then you then have to figure out what the hell is hyperextended. Right? Your AC, your laxity, your quad tendon weak, whatever that could be, itu you punya pasal patella tendon weak, sorry, not quad tendon weak. So now the final thing that you need to think about is placar knee. That could be around the 2 quarters there. Okay, so 1, 2, 3, 4, 5, 6. 6 diagnoses that I can give you for the patella, right? So moving forward for this 2026, if you can, rather than thinking cartilage, start thinking the next column of our layered concept, pathology that could happen in this scenario. Because knowing a cartilage doesn't mean you know how to treat it yet. But when I describe the pathology to the essence of what I teach you just now, you then know how to treat it. And guess what? Because I teach it already, it will be in our knee exam. If you unluckily picked up it's a kneecap,
GG.
oh GG, and you're in the wrong group, itu you.
Watch the video.
No, it doesn't matter because I need everyone to be on the same page. So if I already shake my hands off it, because it's no point keeping it in my brain. My brain doesn't mean that you know how to help your patient. Okay, now for your own structure that you have mentioned, give me the treatment. Boleh? Okay? And Hoyue is going to be the moderator about how it helps. Okay, like Ellie, your structure that you have mentioned, then how you treat it.
Varicosities and fat background. Center Rajesh.
This is real legit question. Why and how? Know the structure, but you don't know how to treat it. Please, the true treatment happens in the functional part of the movement, because this patient needs to get back to high rocks. Right, December. Huh? Ultrasound. So what do you think the ultrasound is doing to neovascularization and of the fat pad?
It's only going to reduce the inflammation, right?
It does, how does ultrasound reduce the inflammation? Without the fast term lah. Just talk about it. Right.
Sound wave.
Okay, it's only an acoustic wave, alright? What does this acoustic wave modulates on? It modulates on the nerve endings that is highly rich in our bursa, which is now sensitized. So you do some ultrasound. Patient comes back tomorrow, same pain again. You put fast term, patient come back 2 days later, same pain again. Come on, something else. What is a bursa? Oh yeah, come on. Moderator, help. Meaning every single condition you also have to help.
Yes.
Should we take it? But
That word's not like this.
What the heck is that?
Naked some more. Only wearing short. He thinks he's very muscular right now.
So cute, love.
Stupid boy.
A few years late, but okay. The death.
should we tape it?
Yeah, so what are we doing to tape it?
Or what are we doing to tape it?
What are we doing?
We're offloading it from compressing the pouch more.
Good. So we need to reduce compression. Find freaking way to reduce the compression. There are ways to reduce the compression. If it's an inferiorly tilted patella, you tilt it upwards. If it's medially tilted patella that's causing the bursa to be sensitive, tilt it the other way. If it's a medially valgusly positioned and that's compressing on the pes ends structures with the bursa underlying it, you support the tendon and tilt the freaking knee that way, laterally. Right? You want to reduce the compression on the area. You put a metal brace on it? No. But do you put a soft cushy thing that deloads this area upwards like that? Yeah, you can use silicone donuts and all that, or you use a K-tape that does that, to create the donut effect as such. You will also, when the person is moving, the pressure is held with a little bit of tension on the KT tape or silicone or whatever that might be there, right? And that is and has to be your management that will make this person better. Would you encourage more walking in a pes ends bursa? Right, you say you need to hit your 5,000, 10,000 steps.
Why is it
Huh?
Maybe gradually?
No,
No,
you don't. You don't encourage walking, but you encourage cycling.
Just offload.
Because you are working it in this position that is not hurting the bursa versus walking bend straight in that position, you are creating bending and shearing onto the bursa. Same thing. If it's a fat pad bursa, what do? Squat? Kneel? Pray? No. You keep your knee extended. Right? You keep your knee extended, you practice your inner range quads to pull the patella upwards, all those things. It's just, you have to understand why. Structure first, then what are you doing to deload the nociception? Okay? Ready? Let's go. MPFL. A unique one, but yeah. Okay. Huh? Taping to prevent valgus. How would you tape to prevent valgus? Yeah. So you have to tape. Tape from the tibia, pull out to. So okay, there is a particular name for that particular tape. To prevent valgus, it's an MCL tape. It's called access. So you have to tap access. You need to have access that crosses this area here, right? Correct? So that's the prevention of biomechanical error. And is it easy to tape it on a patient? Unless he's a sporting background that has a sports trainer that they go to, and then before the rugby game, like in Australia, they're very comfortable for the sports trainer to go, and then we'll just go high stretchy band, loop here, zoop, 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 one whole rep done, rigid tape, pia, anchor. Okay, now still got MPFL. You just prevented me from valgus. So I do generally use the McConnell a little bit, but the opposite direction. Okay, I will first do KT up to create the patellar pouch to hold it in this position, knee slightly bent. Okay. Then subsequently, McConnell generally do two things. One is they have a pull into medial to prevent this one, and they have a tilt to open up this end. Remember McConnell? Jenny McConnell. Oh shit, I guess I'm just a dinosaur. She recently, I just saw her, she was presenting. Jenny McConnell is the person who teach you your patella tapping with the white color and brown color one. I think she is the person who created it, so I kept her name in the thing. But anyway, that just shows my ancient dinosaur. So we do this, but tape, when you do it this way, usually it wouldn't stick because it's a high pivot area. So you really have to remember, one tape, pull, lateral shift. But lateral shift, with it being laterally tilted already, you are just gonna grind it. So you need to make sure, pull already, then you pause halfway, then you pull the medial tilting, and then anchor it down. Faham? So there are two components in McConnell tapping. If you really cannot, you do two way. One, pull like a C curve, like you can do this, C curve, pull it through that way, so that holds the patellar lateral tilt. Then your second pull starts from the middle of the tap. So you do anchorage to the middle of the tap. Then from here, you tilt the patella down and then anchor. So this to this is only this part. And it shortens it. And if you need to, short with it. Faham? So then once it's in that position, load. But usually with this tapping, you cannot enrange knee bend. Enrange knee bend, you will then the tape. Okay? So two components, that's all you need to know. Alright. What was the structure again? Damn, I'm old. Malaysia. Okay, yeah. So quad strengthening in straight first, in full extension. Okay. Yeah, wrong. Because in a chondro Malaysia patella, it's already in a certain position, right? When you do quad strengthening in this scenario, my hypothesis is you're cueing a knee extension isometrics, right? No, what you actually need is superior glide of the patella, which you achieve by intermediates. So either they are yogi that they can learn to pull their kneecap up without extension, pull the kneecap up, and they will just feel some tension here, minimal here. Otherwise, most of my patients will just be here, lean in, feel the isometric here. Because this is knee bending, full knee bending in this position, in just seated, it's safer for them. Why? More surface. More surface area, less focal pressure. So yang ini, our position, squeeze adductor, lean in and hold isometric just here. You're just trying to get your so-called VM, but ideally I only want this IM. IM produces a superior glide in this position. That is the thing that protects our knee when we are in end range squat. Because you need to tension up the kneecap alongside with its, because IM attaches to the capsule. So it pulls onto the capsule and it tightens it so it can then transfer force efficiently through the button so that it can do this extensor mechanism work. So knee extension was often prescribed and that causes more compression force. But if your argument to me will be, but I did my compression and patient is not pain provoked in that position. That's your first statement to me first. Patient is not paying forward. That means you have clearance for knee extension isometrics in extension. Right? As versus to a tibial femoral condition, knee extension isometric absolutely must. Versus in a patellar condition, you need a one-step clearance before you do diastaminal IRQs. This should be a knee flexion isometric, but load it in this standing up position. I called Tutungku when I first gave her the toilet seat exercise. Right, it's almost like you're getting out from the toilet seat, you just load it, but you feel those muscles and isometric near. But no feeling here. Okay? Yours, move on.
With the tape for to prevent lateral medial tilting or like a donut shape EGAs for retinaculum.
Yeah, so retinaculum again, it's about the adaptation of no, to me retinaculum different. It's an adaptation process, or it could be the knee is having too much anterior shift shear.
Anterior shift.
So the femur is moving forward anteriorly a little bit more.
So everywhere, SCL, soleus.
Bukan. This is where I keep talking. I think you hear me mention a quad to hamstring ratio should be 100 to 80.
Oh,
This is where posterior chain weak.
okay.
Therefore, all quad dominant. Therefore, you get bilateral retinaculum. We're not talking about knee capsule lah. We avoid that knee capsule. We talk about the bilateral retinaculum here. Same thing with quad tendon. So what's going on with quad tendon?
For me, I have to do like a cable extension because right now she cannot do like if she cannot put pressure on it. Right? I do a cable extension in like lengthen position to isometric.
Yeah, okay. So we call it isometric eccentric, right? In a lengthened position, we do it in that position. However, this is where you have to be sure. Are we dealing with an antithesis organ? Then may not be the best thing to be in end range, right? So some patients, heavy end range, eventually lengthen out the quad tendon, not antithesis organ. Okay, antithesis organ bend, palpate through this area. I'm on the bone. I push on the bone area in the vector force of the tendon pull. In the vector force of tendon pull, reproduction of pain, I have an antithesis organ. Antithesis organ, load isometric, mid to close to end range, but not in end range. Once you go into end range, you get more pain. And this one really gave me a wake-up call of I have a patient with Achilles antithesis organ problem. Okay, literally I did not restrict the walking, thinking that that little amount of dorsiflexion is okay, right? So we've been doing heel from the floor, coming up, isometric in that position, and then repeats of floor to up. We cannot get over the first step. He was progressively getting worse from like cannot stand for 4 hours, become half an hour, get out of chair, get out of car, antithesis, heel pain, and the swelling in the ankle joint, subtalar joint was all swollen. I can assure you there is no subtalar joint problem. Assume that my clinical skills, right? I can tell you it's only an antithesis organ, but it's causing a proliferation of like gathering of fluid. Wow! So I got annoyed. Asked my good friend. My good friend says, avoid heel to floor and stay up in plantar flexion 2 weeks. Then for 4 weeks, start your heel to floor. Wow, I thought Kitty got difference. Like already heel to floor is quite simple.
Yeah.
It's not going down the step to come up, But for this case, guess what? In 2 weeks, he start 4 hours standing again for meetings. With the end, at the end, he needs to sit down, get out of car, no sharp pain anymore. But cannot go for his long walks yet. I just met him and I was just like, okay, yeah, maybe anticip organ really just cannot go end range. And the tolerance of the end range is different for everyone. And for this guy, it's so sensitive. So literally, I just told him, I think we just go even shorter. If can, I give you heels. Yeah, so now he is on this thing and walking up heels, and I'm just trying to feel how it feels like walking with it without my heel touching down the ground. So it's creating nice beautiful contractions. I'm feeling my foot working and so forth. Alright, good. So now we move back to you. I'm just gonna teach you a few things that I teach in the previous group. Those who attended the previous group will have learned this one. So you all stand up. I teach you how to squat.
Squat with his hands.
Alright, so this squat is trying to think about the few things that we were talking about. Okay, we are squatting without thinking first as we go down into our squat, where you will feel in the squat movements. Okay, and most of the patient with knee pain will start feeling it in the kneecap area. There's a little bit more as you do this. You feel a little bit more around this area here.
Oh, what's that?
Okay, and then coming up. Right, so you feel this is a straight down. This address the mechanics that I was talking about to Leon relative to more anterior shear of the femur hitting onto the kneecap. Then you're feeling a little bit more. Most physio at this point will prescribe isometric wall squats to condition and strengthen out this thing. But there's one missing link here, which talks about if it's a patella. The reason why we teach patella with hip movements is because the mountain groove and the thing that the train and the train tracks. Okay, I use that analogy. So the train is a bit singed to one side, a bit tilted to one side. I can't move the train, but I can move the train track. So now hands on the thighs here. This you will hear me in my notes says Franklin method. Thighs are just around for the hips. So you're using this, okay? And if you want to, you can stay a little bit more position one of ballet, okay? As we go down, we turn the hand, in turn the hips, and we go down and come up. Down and come up. So you're feeling thigh, hip external rotation in the movement. Okay? Then go back to your natural way of squatting. Same thing, hands on thighs, pull and go down and come up. Go down and come up. So what you will feel is a change of load. The change of load when shifted from your original squat form like this, which is pure extensor mechanism, kneecap pressure, to turn. So you're turning the groove of the mountains, the train and the train tracks. Faham? Anyone can feel it? If I can teach it to 60+-year-old, I'm sure my young physios chooks and all that can feel the difference. Okay? Now, it will only matter if the person, it doesn't matter if the person where they already move this way. You'll find when they squat, they are already turning. Because if you don't feel movement here, if you do abduction, your hand will feel differently. You know how they like to push the knee out? So pushing the knee out, you feel in the thigh. If your hand is still here and you feel the bone, you feel the movement different versus turn the thigh to go up. You feel a bit different around the bum and such. Okay, so this is a movement-based approach whereby you need to quantify the person to squat. So ability to squat, sit to stand, 10 to 15 reps of this Franklin method squats. Okay, once they start to know this component, to be fair to last week and this week's group, we have to teach the pelvic floor component as well. Okay, in a pelvic floor, naturally when we go down into a squat, it needs to lengthen. Okay, it cannot let go. Okay, so squat now in your normal stance. Don't think the pelvic floor at the moment. And now you bring your awareness to this area of the butt and this area, and you go down and go. Okay, just feel what is happening. And then now I'm going to give you a inverted pyramid drill. Think in a plie pose again, so it's easier for you to learn. Alright, as you go down, you open the bottom. As you come up, lift. Usually people can feel the lift. Open and lift. So now your awareness is at the bottom of the sling. You open, lengthen, and close as you lift. So if you feel the lift, you feel a little bit of pull into the front of your pelvic floor. Super duper 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 important, because when you start plyo and you're purely, now think if you just do quads, right? You do a quad style wobble and up. There is no support to your pelvic floor. So basically you're just very relaxed there, and then as you squat down, the pressure increases into there, and then you hear them leak. Which is what me and Rebecca are talking about. We really want to change this scenario a little bit. It's just, you need to learn how to squat. That means you're not holding eccentric on the movement of squat. Open, close, open, close. Then they do 10 to 15 of the open, close from a pelvic floor perspective. You do 1 or 2 with the pelvic floor, 1 or 2 without the pelvic floor. Feel the difference that you will feel. One of my patients from immediately pain in the back because the quads is clamping down on the hip. Then the pelvis area is being widened. Think about it. The pelvis area is actually, because the quads is here tight, it widens this end. So it goes to reversal position. Immediately the back pain is one straight line across the back. And all I did was I teach her open, close, open, close, open, close. Then she enjoyed it because she finds squatting first time ever don't use back. I said, it's not that you're not using back, it's just these two are so tight that it's pulling you laterally like this. And you can imagine if this is pulling you like this, it closes down the opposite way. And this is all hip. And the more they train, the hip comes back damn tight. It needs me to stretch them. So that's not gonna work with me. Okay? So we open, close. Same thing when we do deadlifts. Turn thigh, turn back. Turn thigh, turn back. Open to the back, closing back. Open to the back, closing back. I only did at RP of 5 to 6 on Sunday, even this Sunday. Maybe. Cannot. I got swimming with the kids. Anyway, but not my training this weekend. But I'm saying, for you guys, think about this pelvis opening. Last and final piece is staggered stance. When you go forward, in Franklin method, as you start loading onto this leg, the thigh goes external. Right? Now, what happens is, most people, as you load from hip behind the heel, your thigh should go external. Before you step through, the thigh goes internal. Right? So this external component needs to be retaught again. As they load it, you need to pull external. If they don't, you feel that they're internal the whole way through, then they get stuck in this, because they're already in full internal rotation, they cannot get more extension. So it needs to go external, thigh, hand on thigh, external, internal. Then, oh, I open up new range of extension. Okay? And with the back pain patient, how I teach her to run is, as she is landing, her pelvis needs to turn the opposite way. So my hand pulls right to left. So there's a, even I think we started here only. Right to left. So she feel, whoa, first time I feel glute med. As you do that, you create a scissoring action, and you feel in this position, isometric, one of my patients is here, and she just hold this, and she feels her glute. So, okay, good, now transition, play isometric, play isometric,
But it's
play.
top hand just to feel anything like
Top hand is pulling it close.
But is it sort of want to counter force or just like like a Q oblique?
It's more like I would say, this is flanking. So flanking would be probably a fascia pull. So it's probably trying to pull certain fascia a certain way.
Okay.
So this is our cross linkages around here. So he pulled it this way and then pulled it the opposite way, and that works very very well for this.
Because when I pull, I feel my obliques all want to tighten. Is it?
It's not very hard, I'm not mobilizing. I'm just wanting you to feel the movement as it goes here. Feel the. If you pull hard, I think it will end up being like, go, right? Okay. But you see, with this particular cueing, then I can start loading this lady into isometric squats, isometric lunges, isometric step in, isometric lunges. There was a lady that I just literally put one hand there, one hand there. We get to the area where I want her to move like that, and I say stay on this Pilates part, where they get into the tremors, right? Pilates, and then you learn this Pilates part, and then that's where, after that, she's like, wow, I feel so tall when I'm walking now, one side only. My favorite thing to do. Okay, so this is a movement-based approach, provoked, specific at certain time. So movement will best address it. But understanding the structure will then tell you how to get over this sensitization stage. How to, what to avoid. Like we talk about the bursa lah, the retinaculum lah, the patella lah, and all those things. Teaching her how to tape it and so forth. Right? Sometimes pain can cause movement error. Same thing here, error on movement can cause pain in the structure. Right? That's all I want to share. 5 minutes extra.